Hi, everyone. Welcome to the first of 3 presentations from our Washington Integrated Food Safety Center of Excellence. My name is Beth Melius, and I'm the Foodborne and Enteric Disease Program Manager at the Washington State Department of Health, and also co-director of the Washington COE. And I'll be your host for this session. The topic for today's session is Foodborne Epidemiology, Outbreaks, and Investigation Review 2020. So before we get started, we wanted to let you know that this webinar is being recorded and will be made available for viewing later on our website. We will also make our slides available to you. If you registered for the webinar series, you will be emailed when the recording is available. So we are so pleased to host you all today. The Washington COE was established as a CDC COE supporting the western region of the US and Guam in 2019. Our COE is co-directed by myself and Janet Baseman from the University of Washington School of Public Health. Today, our training will focus on foodborne outbreaks and outbreak epidemiology, and is primarily for public health staff that respond to foodborne outbreaks. So here are our learning objectives for this session. If you have questions during our presentation today, please use the Q&A function in Zoom. We will be monitoring the Q&A and we'll take questions at the end of the session. And with that, I'm pleased to introduce our speaker for today. Nicole Marshall is currently a foodborne and enteric disease epi at the Washington State Department of Health. She has previous experience working at a local health department and also has a background in molecular biology. So welcome, Nicole, and take it away.
Hi, Beth. Thanks for that introduction. Like you said, my name is Nicole Marshall, and today's course is going to be a foodborne epi kind of 101 course. This can also serve as a foodborne epi refresher for those of you who may have been entrenched in other disease areas for the last 9 months, #COVID. So today, I just wanted to go over a brief outline of what we're going to cover. We'll be covering the burden of foodborne illness and outbreaks in Washington and the United States. We'll be reviewing the roles and responsibilities of people on an outbreak team. We'll be going through the steps of an outbreak investigation, and then we're going to tie that all together with an outbreak investigation scenario. So we're going to start again with a brief summary on the burden of foodborne illness in the US and here in Washington. So CDC estimates that there are approximately 48 million cases of foodborne illness each year in the US, and that these illnesses result in an estimated 128,000 hospitalizations and 3,000 deaths. However, these estimates are based on what's reported to CDC, so they may not actually capture the entire burden of disease. In fact, it's likely only the tip of the iceberg. So, looking at our lovely iceberg diagram here, the bottom level is representative of the true number of patients that are ill. But generally only a proportion of these patients will visit a physician. A smaller proportion will actually get diagnosed with a laboratory test, and an even smaller proportion will then get reported to the local health department, the state health department, and eventually on to CDC. So for example, for every reported case of salmonella or Shiga toxin producing E. coli, CDC actually estimates that there are probably at least 25 cases that go unreported. So each year in the United States, there are lots of pathogens that cause foodborne illness. So the top 5 pathogens that contribute to illness are norovirus, salmonella, Clostridium perfringens, always have trouble saying that one, Campylobacter, and Staphylococcus aureus. As you can see, some of these pathogens also cause hospitalizations and death. But as you can see, there are some that are responsible for more of just the severe outcomes as opposed to all 3. Listeria monocytogenes is a really good example of this, where a high proportion of the deaths due to foodborne illness may be caused by it, but it has a lower burden of disease. So in 2019, Washington State received almost 2,000 reports of cases of Campylobacter, followed by Salmonella, Shiga toxin-producing E. coli, and so on. These are what we call our reportable conditions, and as you can see, this doesn't include the entire spectrum of pathogens that cause foodborne illness outbreaks. It's also important to note that these are just what was reported last year, and typically in Washington State, we probably have somewhere between 700 to 1,000 Salmonella cases every year, so these numbers are variable. All right, so what is an outbreak? Well, CDC defines this as a similar illness in 2 or more people after consuming the same food item. And we often talk about this as 2 people from different households. Whereas a cluster is defined as the occurrence of more cases of a disease than is expected in a given area or among a specific group of people over a particular period of time. The cluster definition is not an official definition, but it's one often used in investigating reports of disease. And one of the first tasks as an epidemiologist is to investigate whether a cluster of illnesses is actually an outbreak of illnesses. Some turn out to have a common source, while others might just be sporadic cases. Alrighty, so this diagram shows the proportion of disease outbreaks with a confirmed etiology in the United States, separated by those etiologies. Notice the word confirmed here, though. Many outbreaks won't actually ever get that far, so the proportion of unconfirmed outbreak cases by viruses is actually probably higher than those caused by bacteria. For example, each year in Washington, we report a much higher number of suspected norovirus outbreaks than confirmed ones. So these outbreaks are reported to CDC through a system called the National Outbreak Reporting System, or NORS, and they use this to track outbreak reports from the states. Each year they compile submitted data and present it in a dashboard on their website. This is the 2018 NORS dashboard, and it's actually a really great resource. So if I were to go to this page, I can not only find that the average number of outbreaks per state in 2018 was 20, but if I were to hover over our state, I can see that Washington actually had 64 reported outbreaks in 2018, and so we were a lot higher than the average. Next, we're going to go over some of the roles and responsibilities of an outbreak team. So here in Washington, we have 35 local health jurisdictions, and being a decentralized state means that the role of reporting and investigation starts at the local level. However, our locals do have support from the State Department of Health and the Public Health Laboratory, and our Public Health Lab is also a regional laboratory. In Washington State, these are the partners that often work on our foodborne disease outbreaks. In your jurisdiction, it might look a little different, but this is Washington State structure. Our epidemiology section is contained in the Office of Communicable Disease Epi at the Department of Health. Environmental health is comprised of both our DOH Food Safety Program and the Washington State Department of Ag. Our laboratory, again, is the DOH Public Health Laboratory, which sits in King County, Washington. We also have our Center for Public Affairs, which serves as our public information office and our communications team. We again have our 35 local health jurisdictions. And then we have our federal partners at CDC, a regional FDA office, and a regional USDA office that often contribute to large-scale outbreak investigations. So at each LHJ in Washington, they have people that serve as their EPIs, their environmental health specialists, and their health officers. Sometimes there may be one person wearing multiple of these hats, but overall they do serve these core functions. So our single county outbreaks are led by our 35 LHJs, and although most reported conditions are not outbreak related, local health is the first to interview cases when they get reports of new diseases with disease-specific questionnaires. Again, because we're decentralized, DOH also has a specific set of roles in outbreak response. The DOH CDEPI is responsible for assisting LHJs at the county level, leading multi-county and multi-state outbreak investigations, providing disease surveillance of Washington State notifiable conditions, coordinating sample testing with the Washington State Public Health Laboratory, working with state and federal partners such as CDC, FDA, and USDA, and finally reporting outbreaks again to that CDC NORS system that we just talked about. In Washington, we also have some separation of roles when it comes to local versus state environmental health departments. So the state coordinates environmental assessments of implicated food establishments, conducts traceback of contaminated products, and acts as a liaison between local health departments, other states, and to federal agencies. However, it's important to note that the regulatory power in Washington actually lies with our local environmental health programs. Similar to how the Department of Social and Health Services licenses long-term care facilities, local health licenses food establishments. So because of this, they're responsible for conducting environmental assessments of implicated food establishments, collecting and sharing records for product traceback, and when necessary, closing food establishments implicated in an outbreak. Alrighty, so I'm going to pause for a brief minute. That was our first section. I know there's going to be a lot to digest in each section. And we're going to walk you through the steps involved in foodborne outbreak investigation. So throughout this process, it's also helpful to keep in mind that there are two purposes to an outbreak investigation. The first is to prevent additional people from becoming ill, and the second is to learn how to prevent outbreaks in the future. So this is a learning process. Here's a brief overview of the steps we'll discuss today. We'll learn how to detect an outbreak, find more cases, generate a hypothesis, test your hypothesis, solve the source of the outbreak, control the outbreak, and finally decide when the outbreak is over. It's important to remember that outbreaks are dynamic and oftentimes multiple steps happen all at once or out of order. Step 1, detecting an outbreak. Public health surveillance is defined as the ongoing systematic collection, analysis, and interpretations of health-related data essential to the planning, implementation, and evaluation of public health practice. Surveillance is essentially the backbone of our outbreak detection. One method of surveillance and outbreak detection for foodborne illness that you all are probably familiar with is public reporting of complaints. So oftentimes, a member of the public calls their local or state health department to notify them of an illness they believe they got from a dining establishment. From here, local health will often interview the entire dining party to help determine a suspect etiology. Then they'll conduct environmental health investigations, and finally recommend laboratory testing to try and confirm that suspected etiology. Another important part of our surveillance process is notifiable conditions. So notifiable conditions, we start with a lab result and a diagnosis. So it's a little bit different than the one we just discussed. But from here, local health, after getting a lab result and diagnosis, local health interviews with a disease-specific questionnaire to identify common exposures. For example, if we interviewed 3 case patients from different households diagnosed with Shiga toxin-producing E. coli, and they all told us that they ate at a restaurant called Yummy Burger, this would be evidence to initiate an outbreak investigation. We may have detected an outbreak. However, some outbreaks really aren't as initially obvious, and this is where our laboratory methods become really, really important. So in Washington, clinical labs are required to submit patient isolates of Salmonella, S-Tech, Shigella, and Listeria to the Washington State Public Health Laboratory. PHL then confirms and serotypes these organisms. After confirmation, Salmonella, S-Tech, and Listeria isolates undergo a process known as whole genome sequencing. PulseNet is a national laboratory network that connects local and multi-state foodborne illness cases to detect outbreaks across the country. So when the public health lab conducts PFGE or whole genome sequencing, those results are submitted to a national database for comparison. A little bit more about PFGE. This is known as pulse field gel electrophoresis. It is an older method that uses a smaller DNA fingerprint to compare isolate patterns. These patterns are then uploaded to that PulseNet database. And in the past, we looked for temporal matches of patterns. These types of things would trigger a cluster investigation. However, PFGE has recently been replaced by a technique known as whole genome sequencing, or WGS. So what is WGS? This is what we call our next-gen outbreak detection. And unlike PFGE that analyzes a smaller subset, WGS analyzes the organism's entire genome. Because of this, it's considered to be a lot more definitive than PFGE and has a much greater ability to resolve differences between organisms. So this diagram here is what we call a whole genome sequencing tree, and we affectionately refer to these as the branches. So as you can see, when you have things clustered on a branch like this, they're considered to be more highly related than something down here on this branch. So now that we have our initial information, we wanted to start to define our outbreak criteria. A case definition is a really good place to start. A case definition is essentially just a list of criteria used to determine if an individual is included as a case in an outbreak. And a case count is a number of illnesses that meet that case definition. So your goal in building your case definition is essentially to define the who, the what, the when, and the where. So I just made this case definition up, but a case is defined as a student or staff member at Riverdale High School who has an onset of diarrhea being at least 3 loose stools in a 24-hour period, vomiting and or chills, and who onset between July 4th and July 14th. So as you can see, we have our who, which is our students and staff members. We have our what, which is our clinical description of diarrhea, vomiting, and chills. We have our where, which is Riverdale High School, and we have our when, which is our onset dates between July 4th and July 14th. Now we want to start doing some descriptive epidemiology, and here we might start to collect data in a format known as a line list. So a line list is used to both summarize the characteristics of cases and compare exposure information. We look at things like location, gender, age, language, race, as well as known ill contacts. It's a really handy summary tool, and oftentimes you might ask to provide things like median age, percent of hospitalized cases, possibly to your communications team, and this is a really easy tool for generating that information. Also notice that we included here exposure information from each of the interviewed cases. This is going to come in handy later on. So the next thing we want to do is generate an epidemic curve, or an epi curve. And the reason we do this is to look at the patterns of onsets, because it might actually give us a hint as to what type of outbreak this might be. So epi curves can be really, really helpful clues. For example, if we see a tightly clustered shape with a single spike, we might suspect a point source outbreak. An example of this would be a single shared meal where everything is clustered within one incubation period. A common source outbreak, such as a product on grocery store shelves, shows us a much more extended epi curve pattern with peaks and falls as a product is recalled by distributors. A person-to-person outbreak might look a lot more consistent or continuous, with a sharp drop-off after there are no more exposures. You might also have spikes that correlate with more than one incubation period for the illness in question. All right, so step 2. We're going to talk about how to find more cases. So the same notification system or foodborne illness complaint system where you first found cases is often one of the best places to start to look for more cases if your pathogen is unknown. However, if you do know the pathogen, there are a lot of resources for case finding, and a few of them are listed here. So we can use our laboratory reports, such as whole genome sequencing reports from PulseNet, clinical lab results from routine disease surveillance reports, special reporting by labs and clinicians. You can also review emergency department records for mentions of similar illness or pathogens. You also might want to survey groups that have been exposed, such as fraternity members at a party, maybe a school classroom or a daycare, depending on what your outbreak is. And then using your partners at other health agencies, such as your local health department or other local health jurisdictions, to spread the word and be on the lookout for additional cases. It's also important to note that there are delays in outbreak recognition. So we wanted to go over an example timeline of how long it takes from the onset of illness all the way to linking a case to an outbreak via whole genome sequencing. So it starts with the day someone is exposed to salmonella, right? On average, it takes probably about 1 to 3 days for someone to start feeling ill. And from there, it might take them up to 5 days to even seek healthcare, depending on how bad they're feeling. And like we discussed earlier, the people that are seeking healthcare are only a small proportion of the initial cases. Next, a provider may request a stool sample from the patient, which then takes about 1 to 3 days for initial testing to be completed. From there, the specimen is shipped to a public health laboratory where culture confirmation, serotyping, and whole genome sequencing, or PFGE, are performed. In total, that process takes anywhere from 2 to 10 days. After that, results from whole genome sequencing are uploaded to the national database, that PulseNet database, where they are matched to other cases. And finally, from there, once we have those matches back, we can confirm that our cases are a molecular match, and we can report them as part of an outbreak. As you can see, this entire process can take up to a month, and this often affects our investigations because we often interview patients about foods eaten over a month ago when their memories may not be as fresh. Next, we're going to talk about generating our hypothesis. So sometimes your case interviews will suggest an obvious common source, like the yummy burger example. However, most of the time, it's not quite so simple. So in these cases, you would want to consider using a hypothesis-generating questionnaire, often referred to as a standard NHGQ, to interview cases. And these types of questionnaires contain a standard list of food items. It also contains each meal the person ate during their exposure period, probably their shopping habits, potential travel to other counties, states, or countries, meals out at restaurants, and essentially any other type of food eaten outside the home, with the goal being to capture all possible food exposures. From these NHGQ responses, you would create a list of common foods and drinks, which, if we go back to our line list, that's a really handy place to record those. And this list, aggregating this data often allows us to make a best guess about the likely source of the outbreak. However, there are some instances where an NHGQ might not lead to an exact testable hypothesis. And in these scenarios, you might consider more time-intensive, open-ended interviews. For example, when CDC was investigating an STEC outbreak associated with baking flour a few years back, the way they were able to identify this was through open-ended interviews, where we learned that cases had been baking and occasionally ingesting raw dough or raw flour. Traditionally, flour isn't on something like a standard questionnaire because it's not intentionally consumed raw, so it's not a standard food per se. Next, we want to test our hypothesis. So there are both epidemiologic and environmental health methods of testing a hypothesis. One way to test is to conduct an epidemiologic study that allows you to compare ill and well people and assess the exposures of interest that you identified in your previous hypothesis-generating interviews. I'm not going to go into depth on these today, but a couple examples of these types of studies are cohort studies and case control studies. So an alternative would be sampling food or environmental specimens, and this is a common way to use environmental health resources and laboratory methods to actually test your hypothesis. And this type of testing can lead to big breakthroughs in your investigation. Speaking of breakthroughs, we want to talk about solving the outbreak. So there are multiple ways to identify the source of the outbreak. Statistical analysis of interview data, evidence gathered at an environmental inspection. So if, for example, you went out and you saw potential for cross-contamination, or you identified a bunch of ill employees, product traceback for the production chain of the food item in question, and then test results from sampling of implicated food items. And positive evidence in one or more of these categories can really help us identify the source. So during an outbreak, we often talk about the three-legged stool of investigations, and you may hear members of outbreak teams referring to solving the outbreak in all three legs. This is because in an ideal scenario, we would be able to show microbiologic evidence of an outbreak, meaning that the clinical isolates are closely related, and that we've shown evidence of the outbreak strain existing in either the implicated food, where the food was processed, or where the food originated from. So we also want to show an epidemiologic association between illnesses and exposures, such as a statistically significant exposure for the cases compared to those who are well. We also want to make sure we trace back the source of the product so that we identify a common source of contamination. For example, if we identified that the vehicle of our outbreak is red onions, we want to know everywhere those onions were distributed so that we can intervene appropriately. The next step is controlling the outbreak. So once we identify a source and solve our outbreak, it's important to take quick action to prevent anyone else from becoming ill. And some things we might consider doing to prevent illness are cleaning and disinfecting food facilities, temporarily closing a restaurant or processing plant, recalling food items, telling the public how to make the food safe, such as cooking it to a certain temperature or even just avoiding it completely, telling consumers to throw away the suspect food product from their pantry or refrigerator, or restricting cases until they are no longer contagious, such as those ill employees in a food establishment or in another high-risk setting. It's also important to have a strong communications presence throughout your outbreak. So communication is key both during and after. And communicating messaging about things like avoiding food items can and should take multiple forms to reach as many people as possible. So consider things like press releases, social media posts, press conferences, and text alerts so that you're able to reach as many people as possible. So how do we decide when an outbreak is over, right? We've identified our source, we've solved it, but now what? This is where it's really important to refer to your routine surveillance. So the outbreak is considered over when the number of new illnesses goes back to the normal expected number. So being able to detect when you're back to your baseline level of illness, which might be 0, is important for determining that the outbreak is over. Alrighty, I know we've digested a lot of information, but we're also going to walk you through an investigation scenario that ties together everything we've just been talking about. So this investigation scenario is based on a real outbreak that occurred in 2014, where Washington State investigated a local outbreak of E. coli 0121 that eventually became a multi-state outbreak. Alrighty, so E. coli 0121 is a type of shigatoxin-producing E. coli, or STEC. The reason these types of E. coli are really concerning, though, is that they can cause severe illness, such as bloody diarrhea and kidney damage. The most concerning type of STEC is actually E. coli 0157H7, and this is the most prominent type of STEC causing illness in the U.S. But some serogroups of non-0157 can still cause severe forms of illness, like the E. coli 0121 that we're talking about today. So getting ready, and even though we're starting with step 1 here and that we presented the steps in a systematic order today, it's important to remember that often in outbreaks, things don't happen in a nice, clean, orderly fashion. Most outbreaks will have multiple steps occurring out of order or steps occurring concurrently. And so I just want to keep that in the back of your brain here. We've kept the steps labeled to orient you to the previous section of the presentation, but just kind of making sure that that sinks in. Alrighty, so let's begin, right? Day 1 of our investigation, Monday morning. The Washington State Department of Health Foodborne Epi team received a call from Spokane Regional Health District about 4 shigatoxin-producing E. coli cases. 3 of the cases had reported eating at the same chain restaurant. Later that day, the Foodborne Epi team also received a call from our lab colleagues at PHL, stating that they had identified that all 4 of these E. coli cases were in fact the same type of E. coli 0121. So they had done that initial serotyping. So this was super interesting, right? Not only have we possibly detected an outbreak from notifiable conditions reporting, but we also have our laboratory surveillance. Next, the local health department conducted initial interviews using the Washington State STEC case report form. And from the first 4 interviews, we saw that 3 of the 4 patients had mentioned eating at restaurant A. However, 3 of the case patients had also consumed sprouts. But the 3rd person who consumed sprouts actually ate these sprouts at a separate restaurant, which we'll refer to as restaurant B. So at this point, we have a couple of working hypotheses that we want to pursue, right? We have that restaurant A, we have sprouts, and then we also have this link to restaurant B. So we decided to do more information gathering. And based on that information from these first 4 cases, on Thursday, Environmental Health visited both restaurants and began a rapid traceback of sprouts from both restaurants A and B. From this, it was found that restaurants A and B received sprouts from the same producer in Idaho. We'll call this producer A. The restaurants were asked not to throw out any sprouts they had received, but to cease serving them. So this process of information gathering ended up actually turning into an important control step. The distributors were also asked to hold all sprouts from this producer, and environmental health teams made sure to collect and hold the sprouts from both restaurants. 4 days later, 6 additional cases of E. coli 0121 had been reported to state health departments. Sprouts from any newly mentioned restaurants were collected for testing, and a supplemental questionnaire which contained more questions about sprouts was created and deployed for newly added cases. So taking a step back, we want to continue to generate a hypothesis, right? So I mentioned that supplemental questionnaire. The hypothesis generating interviews using that new sprouts questionnaire were conducted by local health. And from these interviews, local health noticed the following: that there were 7 of 7 mentioning consuming sprouts, 2 of 7 consumed tomatoes, 1 of 7 remembered eating cucumbers, and 5 of 7 noted that they owned cats. Local health also noted in this investigation that it was pretty difficult to obtain exposure data from ill cases because a lot of them couldn't remember their sandwich ingredients, which is not uncommon, right? Sometimes you order the one thing off the menu and you're like, I don't know, it probably had tomatoes. So trying to kind of sift through that and nail down that information is also really important. But what do we do with this information? It's important to note that sometimes you do get answers that can be significant, but not the source. And it's still important to investigate these and not let your confirmation bias creep in. So I know at this point we seemed really focused on the sprouts, but we still wanted to make sure that we were looking at all potential hypotheses. So after further investigation by local health, even though there was a high proportion of people who owned cats in this outbreak, it was unlikely that these were the cause of the illness due to the fact that these were not new cats or they were not from a common breeder. Essentially, we couldn't find anything in common with these cats. But a lot of times, especially at restaurants like this, you'll see like everybody is eating a couple of different things, and it's important to make sure that you're investigating all possible sources. So the next day, the PHL lab notified us that these 7 cases were all indistinguishable by PFGE. Remember, at this point in time, all we had was that E. coli 0121 serotype. But this molecular characterization confirmed that these cases were highly related. Note, if the outbreak was actually this year, we would have used whole genome sequencing instead of PFGE to determine if the isolates were related. But this was the technology we had at that point in time. Now, you might be wondering why we didn't talk about a case definition before. In this case, things were moving so quickly, right? Like we were starting on Monday, we're only back to the following Tuesday, so we're within about a week. But it was important to take a step back and make sure that we were defining our cases. So a confirmed case in this outbreak consisted of the following things. So this was a person diagnosed with E. coli 0121 infection with an illness onset between April 15th, 2014 and June 25th, 2014. And it was also important that their isolates match the PFGE pattern in question. I know this looks jumbly, but notice we might be missing a where also. You know, we talked about the where before. In this case, the where is the broader US. So at this point in the outbreak, there were cases from multiple states. And so we thought that this had the potential to turn into a larger multi-state outbreak. And we didn't know how far the potentially implicated products had actually been distributed. It's important to remember that your case definition is fluid and can change based on the information you continue to gather. Next, we wanted to test our hypothesis. So at this point, we had molecular evidence that these cases matched, but we also wanted to explore epidemiologic evidence. So 16 cases had been included based on our case definition, and of those 16 with info available, 13 or 81% reported eating raw clover sprouts during their exposure period. One really useful resource we used to determine if this was significant was something called the FoodNet Atlas FoodNet Atlas of Exposures. And this is a public resource, and it's based on a survey of random US households that shows the percent of the population reporting eating a certain food item in the past 7 days. So this is what we would call a background rate of consumption. Using this atlas, we found that only around 8% of the US population reported eating clover sprouts in the past 7 days. And so when we look at the percentage of cases in our outbreak, 81, compared to that background rate, it is a statistically significant difference. So after all of this information gathering, DOH quickly put out a news release pertaining to stopping the consumption of the sprouts in question. And the goal of this media release was to prevent the public from buying or eating the sprouts or have them throw away any existing product. Because our goal, remember, is ultimately prevention, right? One of our 2 main goals is to prevent others from getting ill. And so this led to restaurants stopping serving these sprouts, which ended up being a really key control step in this outbreak. All right, now moving back to step 5, we do need to solve the outbreak, and that starts with identifying a source. So this came from a combination of factors, as you can see here. FDA conducted a product trace forward where we found that producer A supplied raw clover sprouts to 7 restaurants where 9 of the ill people had reported eating. There was also seed traceback done, and we found that these seeds were common clover seeds that came from a grower in Oregon, and that these seeds were labeled as not fit for human or animal consumption. Unfortunately, even though we did get seed and finished product samples from producer A, they all tested negative. So that was a little disheartening, but there was also an inspection of the producer A plant that was conducted. And this next slide shows you the results of that inspection. And what FDA found was pretty clear evidence of contamination of the product. And I wanted to show you a few interesting anecdotes. They noted that 2 employees using tennis rackets to scoop mung bean sprouts had scratches, chips, frayed plastic, and sponge-type handles that had the ability to hold on to things like bacteria. They also saw an employee using a pitchfork with visible corroded metal and rough welds to transfer the mung bean sprouts during the harvest. They also saw that an employee was observed using a squeegee with visible corroded metal and non-treated wood to agitate the mung beans when soaking. And so there was a lot of things going on at this plant that led to this environmental evidence. So all in all, some key findings and a little bit of a summary is that we had 19 PFGE confirmed cases from 6 different states. Illness onsets ranged from May 1st to May 20th, 2014. Ages ranged from 11 to 52 years. 68% were female, and 44% of cases were hospitalized. So that's a really high proportion of hospitalization. Thankfully, there were no deaths. Going back to our epi curve that we discussed earlier, this resembles what we might expect for a common source outbreak, right? Where we have some peaks and valleys coming up, and it spans a couple of incubation periods. And your epi curve can be used as both an exploratory step and a summary step, so it's helpful in both instances. But now we had traceback evidence suggesting a possible contamination at the producer level. We had molecular evidence linking all of these cases together, and we had epi evidence showing a higher than expected sprouts consumption among these cases. So how do we decide when this outbreak is over? We did decide that this outbreak of E. coli 0121 was caused by raw clover sprouts. An Idaho sprouts producer was implicated as the source. However, there was actually no voluntary recall from this producer, which is one reason why our media releases and product holds at the distributor and restaurant level early in the outbreak were so important for preventing additional illness. Remember, we had those multiple means of control, which seemed maybe out of order, but were really necessary for this. Eventually, producer A did discontinue the contaminated seed lot, but it was about a month after the last case had been found. So is this outbreak over? In this case, we had no further cases of E. coli 0121, which is our baseline, so the outbreak was closed. And I'll take questions on any of this in just a couple minutes, but we're going to finish up with a few tools and resources. So here are some tools and resources that we can recommend for further information on outbreak investigations. We have our Washington Center of Excellence here, who's putting on this lovely webinar series. We have our Tennessee Center of Excellence, our New York Center of Excellence, and our Colorado and Minnesota Center of Excellences, which all have really awesome resources. PulseNet is also a really good resource for laboratory methods, and then the CDC website also has some awesome recent salmonella outbreak examples if you're looking for more. All right, at this time we'll take questions.
Yeah, thanks, Nicole. That was great. This is Beth again. I just wanted to thank everyone again for joining us today. I hope this was a nice break from the ongoing COVID work that everyone is still doing. So we are open for questions. Just use the Q&A function in Zoom if you have any questions. Thanks. So the first one is, were there any consequences for the producer? FDA did work with the producer, so they would have more information on that. Like we said, they did not voluntarily recall, which is unusual in a producer, but I'm not exactly sure what happened with FDA and the plant. Another one, does Washington follow up on all CAMPs? No, we do not. We do our best. Those are through the local health jurisdictions, and right now some people are actually calling all of our CAMPs in some local health jurisdictions, but in others, they just send out a questionnaire and hope to get it back by mail. Another question, other states are using red cap surveys for the public to report. Oops, it's going too fast. To report illnesses. Is this being considered for Washington? Thank you for asking. Yes, we're going to be doing something with Colorado Center of Excellence. They're using red cap for both CAMPI and Giardia. So we will be piloting that this year in one or two of our local health jurisdictions. And then another one, was there a rapid notification used to alert the restaurants to discontinue use, or was this communicated through a public notification release? So I believe at the time, our environmental health folks at the state and our local ag notified all of the restaurants that we knew that were getting these sprouts to discontinue use. So it was public notification, and at the same time, EH reached out to those restaurants. Let's see. Other states, oh no, here we go. Do you have any recommendations or advice for an early career individual new to foodborne outbreaks and investigations? Janet, you can answer this too. You want to try that one?
Well, I think this question is probably for somebody working in a Department of Health. So you or Nicole is probably better positioned than I am to answer that.
Okay, well, what I would say and what I did when I first started in Foodborne was I just tried to get on as many trainings as this, to increase my knowledge. There's not always the best training, once you get into a health department. So a lot of it is done on your own as well. I would just soak up as much information as you can. You can always ask us questions, and you do have help from all of the other COEs, and lots of really good resources that we actually pointed to a few on the slides that you can look at later. So what I would say is, yes, get to know your laboratory people, your environmental health folks, and any of the foodborne epis that you know, and just really absorb as much information as you can. And ask a lot of questions, because everybody in the foodborne world is eager and willing to help.
Yeah, I'd also like to contribute to that response, Beth, in that I think it's also important to know that no outbreak goes perfectly right, so you don't want to beat yourself up for mistakes. It's important to, like we said in this process, right? It's an iterative process. We're learning how to prevent outbreaks in the future. So I think that's one of the most important things somebody earlier in their career should keep in mind, is that it's okay. Things will never go perfectly.
Okay, another question. Thank you for the informative. Are there any foodborne disease case studies that describe dealing with chemical contamination of foods or maybe intentional contamination of foods? I don't know the answer on that. Do you, Nicole?
I'm not sure if I know of any specific case studies dealing with chemical contamination. If there were, the COE resources that we presented would probably be the most likely place for those. So those would be a good place to check out.
Here's another one. Besides the poor equipment used in the Sprout facility, did any other factors show how the 0121 entered the facility? So those are just a few of what FDA noted about the plant. There are a few more. Different things that they noticed that we did not pull out of that report, but it is available online. Will there be more trainings on foodborne outbreak or refresher courses in the future? Well, as a matter of fact, the next 2 Thursdays, we have two more webinars coming up. So next Thursday, we have a presentation from Janet Anderberg, who is an environmental health professional, about food safety roles in outbreak investigation. And then the following Thursday, same time, 11 o'clock, we will be having a whole genome sequencing for EPI's talk by Cassandra Allen. So that's what we have. There are other COEs that are also working on other webinars and trainings, so just stay tuned to the COE websites as well and notifications. Another question, I noticed the background food consumption rates were from a 2007 survey. Is that updated regularly? So to my knowledge, they're trying to do another background survey, but I am not a part of that. I believe that CDC, maybe the FoodNet sites are working on that. But we can find out and let you know, Steve. Am I missing any? Oh, here we go. Can we receive certificates for watching? That's probably, Janet, do you know if we have certificates?
Yeah.
Or can we get some?
Yeah. So our team is looking into that. We have to request them for certain types of credit, and the team, we wanted to get these trainings up as soon as we could, and the team is still looking into what types of certificates, for continuing education we can get. And when we have that information, we will email that to everybody that was registered for this training. And speaking of sending you an email after the training, I also just wanted to mention that we will be posting the recording for this presentation today, and also the slides for anybody who would like to review the content again. So you can look forward to being able to access those materials, in addition to any information we get about continuing education credits when we have that information available, and we'll ping you all.
All right. Let's see. Can you please describe again the multiple factors that made you decide to alert the public about not consuming sprouts? Nicole, you want to take that one?
Let's see. I'm looking for it. I'm sorry, I'm not finding the question. Was there a rapid notification? Which one? Can you read the question one more time, Beth? I apologize.
Sure. Sure. It says, can you please describe again the multiple factors that made you decide to alert the public about not consuming sprouts?
Sure. So at that point, let's see. You can go back in the investigation too. I'm guessing that you're talking about this point, our control the outbreak step. So let's look at kind of right before that. We had tested our hypothesis, right? So we had statistical evidence or a statistically significant difference in the rate of consumption. We also had PFGE patterns of patient isolates that were indistinguishable. And our hypothesis generating questionnaires really pointed towards sprouts as the source of the outbreak after we had investigated additional sources like the cats we had talked about. So it was a culmination of all of these factors, right? As well as the fact that the clover sprouts from all of these restaurants that people had been eating were coming from the exact same source. So it was really a combination of all of those things.
All right, another question, probably for you, Nicole. What recommendations do you usually give for a person who tested positive for one of these illnesses? So like at the local level.
Sure. So we actually have notifiable conditions guidelines here in Washington State. And so people who work as investigators at the local level do give give recommendations based on kind of a general public health recommendation. A lot of times those things are centered around great hand hygiene, hand washing, making sure that we're not spreading it within households. Local health will also interview about occupations to make sure that somebody maybe isn't working in a high-risk setting where they might spread this disease, right? So we're still really working a lot on those prevention techniques. And a lot of that happens at the local level when they're doing those interviews. With STEC in particular, there may be some more specific recommendations because of the complications it can cause. But again, those are generally in the notifiable conditions guidelines for each state. So I hope that answers your question.
Okay, here's another one. In the presence of strong evidence, does local EH have authority jurisdiction to initiate an environmental investigation, or does the suspected source facility have to invite or approve an EH inspection?
So a lot of times I would say it's a collaborative approach, but ultimately, right, here in Washington, EH does license these facilities, and so they do regular inspections on top of these environmental assessments for outbreak scenarios.
Okay, is there anything else I'm missing? Oh, someone said that they would recommend the EATS 101 and 102 available on the CDC website. So I'm assuming that's a training that would be good. Did I miss any more? Oh. With these multi-agency outbreak responses, what do you see as one thing that could go better with interagency collaboration and one thing that works really well already? Do you want to start and I can add, Nicole?
Sure, definitely. We're lucky here that in Washington we have really great relationships with our other agency partners. So I think this question actually came from WSDA. So we really appreciate that we have those types of collaborations, and it makes it really, really easy, the fact that we have those open lines of communication. In terms of things that could go better, I think sometimes in outbreaks, we sometimes get caught up in the moment, and we need to make sure that everybody is informed of like what's going on at each point in time. So I think one thing we could do better is probably having more regular updates for everybody involved in these outbreaks. Beth, would you like to chime in?
Yeah, I would say the same. I mean, communication and communication. I feel like what we have now, we have a great team here in Washington with our local ag and FDA folks, plus our local health jurisdictions, and we're able to respond really well because we have such great ties with them already. We meet regularly with all of us to talk about outbreaks, and I think it's just really important to keep that communication going and know who to call when you need that person. So that's really, really helpful. And what we could do better, I mean, there's always the sharing of information we could always do better, I think, and just even better communication than we're doing now is helpful because, like Nicole said, when you're in the moment, it's really difficult to remember everybody, but that's really important to do. Okay, I think we have about a minute left. Let's see. Is there one more? Oh, is there a difference to outbreak inspection at manufacturing plants or other guidance for these types of facilities? You want to start that one, Nicole, or do you want me to take that?
You go right ahead, Beth.
Okay, so there are differences in restaurants. Our local health jurisdictions can go into restaurants. In manufacturing plants, that's more of a local federal agency that would go in, and we will be talking a little bit more about this next week in the environmental health webinar. So I encourage you to join that one as well. They'll tell you more about those differences.